minutes.
Hello, everyone, and welcome back. Sorry for the technical snag in the beginning. We apologize and thank you for your patience. And we are back. And Dr. Joshi, over to you again. So, Dr. Joshi will present the second part of his lecture on extended Ewing family tumors. Over to you, Dr. Joshi.
Thank you, Dr. Rifat Manan, for giving me this opportunity and including my webinar in your series. The title of this presentation is given here on this slide. I'll be giving part B of this presentation today. I would like to thank uh, for providing articles, data, photos, and for sharing cases to Dr. Smith, Dr. Wong, Dr. Ranganathan, Dr. Kumar, Dr. Mandavili, Dr. Balarazo, Dr. Bakshi, Dr. Muradi, Dr. Jayalakshmi, and Dr. Nat Pernig and his colleagues at Pathology Outlines, and to all the authors of review and focused articles on extended Ewing family tumors and of other online materials. I also thank IPNA for sponsoring my webinar. So what I'm going to do today is to briefly review part A and then go on to describe the Icc profiles and give you the genetic markers of these tumors. What it does is that knowledge of Icc profile for each tumor will enable you to order particular stains, Icc stains, which match the working diagnosis that you have made on the basis of histology. And if the Icc stains, the Icc profile strengthens your diagnosis made on histologic grounds, you will be able to request targeted tests for molecular genetic markers. So after that, I will briefly review the merits of the technique FISH and then say a few words about next generation sequencing as a diagnostic and research method, and a few words about clinico-biologic relevance of molecular genetic markers. And I will briefly summarize what we have discussed in these two presentations. So you have a working histologic diagnosis. So the next step is to request the set of Icc markers which are suitable for strengthening your working diagnosis. And when you do that, and if your diagnosis is strengthened, then you take the next step of requesting the genetic marker. So the Icc markers that I'm giving in this presentation are based on my personal experience and literature review. But when it comes to your choice of these markers, you have to depend on your own personal perspective and your resources. Because the total panel of Icc markers consists of more than 25. And what we can have in practice in terms of the resources and conserving resources and reducing costs is something that you will be able to decide on the basis of your departmental and personal choice. So these are the 5 different entities that we are going to talk about in terms of their Icc profiles. Ewing sarcoma, then EWS NAFT-C2 fusion sarcoma, and EWS PAT-Z1 fusion sarcoma, and the other tumors that I have listed here on this slide. So, as I mentioned to you in part A, these tumors basically belong to the broad group of small round cell tumors in children and adults. And there are 2 sets in these broad group of Srcds. The first group consists of established Srcds with demonstrable line of differentiation by histology and other means. And there are 3 subsets in this broad group. And the second group is the EEFTs, which consist of undifferentiated small round cell tumors. And we are going to talk about these in these presentations. So just to remind you, there are three subsets in the established Srcds. The first subset is conventional spectrum, consisting of neuroblastoma and other tumors listed here on this slide. The second subset is the small round cell variants of tumors such as osteosarcoma and other tumors listed on this slide. And the third subset is the biphasic sarcomas with small round cell component such as in mesenchymal and myxoid chondrosarcoma and myxoid liposarcoma. So these are the three subsets of the established small round cell tumors. Amongst these, the main tumors which need to be considered in the differential diagnosis of EEFTs are listed on this slide. Neuroblastoma, embryonal rhabdomyosarcoma, showing dense pattern, alveolar rhabdomyosarcoma of the solid variant, and lymphoblastic CD45 negative, CD45 positive non-Hodgkin's lymphoma of bone, and the small round cell variant of osteosarcoma. But as I have said in my first presentation, we have started these presentations with the assumption that all these aforementioned entities in the subsets of established pediatric and adult Srcds have already been ruled out by similar stepwise approach, and now we are left with differential diagnosis of EEFTs. So on the basis of histology, I told you last time that we have divided these EEFTs into two groups. The first group consists of just one tumor, that is Ewing sarcoma, and the second group is non-Ewing sarcoma. So we are going to now start talking about the Icc profiles of these tumors. My colleague at Hartford Hospital, Dr. Carton, calls it morphologic proteomics for the reason that Icc indeed identifies proteins morphologically within the cell or at the surface of the cell, that is within the membrane. There are certain important considerations in Icc. The first one is the type of antibody that you are dealing with, and I have given the different types of details of these considerations. For example, in desmoplastic small round cell tumor, you have to have a C-terminus antibody. In other tumors, you have the N-terminus antibody for Wt1. Second consideration is the pattern: nuclear staining, cytoplasmic staining, membranous staining. And then the extent of staining, diffuse or focal, the degree of staining, weak, moderate, or strong. So it's not just plus minus, but all these considerations are to be taken when you review the slides of an Icc stain. And you have to note also that there is an overlap Icc markers, and CD99 is a prime example of that. CD99 is positive in Ewing sarcoma and also in variable proportion of other EEFTs. So because of this overlap, individual marker by itself is of limited value in terms of diagnosis of an individual EEFT. So what we need actually, I would say, is a printout in front of you, a printout of profiles necessary in front of you for strengthening the histologic working diagnosis. I'm saying a printout because it is difficult to remember these numerous Icc markers, and therefore it is better to have a printout in front of you, which you can get later from the PowerPoint slides I have, which when it becomes available to you. The gold standard for definitive diagnosis of all these tumors is demonstration of gene fusion by different tests. The nearest Icc marker that comes to this gold standard is the one in which we identify the fusion protein. And there is an example of this recently described for synovial sarcoma. In synovial sarcoma, now we can have an antibody for the fusion protein, that is SS18 SSX fusion protein, which has 100% specificity and 95% sensitivity, according to a recent publication, which has been also confirmed by another publication. This type of antibody comes closest to demonstration of gene fusion and has been called as next generation Icc marker. This is the photomicrograph of the poorly differentiated synovial sarcoma showing SS18 SSX positivity. In this particular slide here, the other case of PDSS in this series was negative, so that you can see that the sensitivity can differ, but as it has been shown by these authors, it is 100% specific for synovial sarcoma. So such antibodies, it has been pointed out by these authors, could replace molecular genetic testing for fusion transcripts or cytogenetic teasing for translocations. And therefore, these have been called next generation Icc markers. Such antibodies for EEFTs are not yet available, but hopefully they will become available in future. So what does knowledge of Icc profile does for you? What it does for you is that it strengthens your working histologic diagnosis so that you are able to request the targeted uh, tests for genetic markers. And when you have the knowledge of Icc profiles, you can make a choice regarding which of these markers you want to use in your laboratory to conserve resources and to reduce costs. So let's start with the Icc profiles of these individuals' tumors. The first group is Ewing sarcoma, and the second group is non-Ewing sarcoma. So let's start with Ewing sarcoma, both typical and atypical large cell Ewing sarcoma. This is the histologic picture of a typical Ewing sarcoma. This is the histologic picture of atypical Ewing sarcoma. We won't go into the details of all these pictures right now because we have already done that in part A. And in the interest of saving time, I will just quickly project these pictures for you without saying anything about the details. Now, let's start with the Icc profile of Ewing sarcoma. There are positive results, positive markers, and there are negative markers. So the positive markers include CD99. And remember the pattern of staining. This has been emphasized over and over again in the literature, and it is very important that it should be diffuse, strong, crisp membranous staining. In Ewing sarcoma, this type of staining can be seen in non-ES tumors, but it can also be cytoplasmic and focal and weak staining in other tumors. In Ewing sarcoma, it's always diffuse, strong, crisp membranous staining. The next marker is NKX2.2. Then Fly1 and PAX7 have also been mentioned. Neural marker will be plus minus depending on whether that particular tumor is showing neural differentiation in terms of presence of rosettes. And this type of profile will support a typical Ewing sarcoma with or without neural differentiation, and also support atypical large cell lymphoma. If you have a variant of typical Ewing sarcoma in terms of epithelial differentiation or adamantinoma-like pattern, you will need to have focal demonstration of cytokeratin or high molecular weight cytokeratin in the tumor. So these are the Icc markers which show positive markers, positive results. There are markers which show negative result, Wt1, TLE1, Desmin, and so on and so forth, which are listed here on this slide. I will emphasize FOX2B for the reason that this particular immunostain is specific for neuroblastoma, where it is negative for Ewing sarcoma, and neuroblastoma figures prominently in the differential diagnosis of Ewing sarcoma. But as we have already said, these established Srcds have already been ruled out. So we are going to confine our discussion to EEFTs. This is the diffuse, strong, crisp membranous staining for CD99 in a Ewing sarcoma. This is the high power view of the same. Notice also that when you are looking at these slides of immunostains, you can also see the features of routine histology, which enable you to get some idea as to what type of tumor you are dealing with. I will not go into the details of this. I have already told you about this. So you can remind yourself of what those features are, and also try to note these in these slides, in which I'm mainly emphasizing the Icc markers. This is just to show you that CD99 can be positive in non-ES. And this is an example of EWS NFAT C2 fusion sarcoma. And as you can see here, the CD99 is positive in these two photomicrographs C and D. Here it is cytoplasmic dot-like, and here it is diffuse. Here it is membranous strong staining, although it is not diffused. In this part, it is showing cytoplasmic staining. So please remember that it has to be diffused, strong, crisp membranous staining in Ewing sarcoma. CD99 is positive even in the small round cell tumors belonging to the established group. For example, here the CD99 is positive in synovial sarcoma, the bottom picture, and the top picture is that of Ewing sarcoma. The adjunct to the workup of immunocytological workup of Ewing sarcoma is the NKX2.2, because we need this because CD99 shows an overlap. So CD99 combined with NKX2.2 will provide a very strong evidence that you are dealing with an Ewing sarcoma. And this is the photomicrograph of that stain to show you diffuse strong nuclear staining for NKX2.2. If you have a variant of Ewing sarcoma showing epithelial differentiation or adamantinoma type pattern, you will need to demonstrate the keratin or high molecular weight keratin. And this part of the photomicrograph shows that the small round cell component of this Ewing sarcoma shows CD99 positivity, characteristic CD99 positivity. So on the basis of these stains, you have strengthened the working diagnosis of histologic diagnosis of Ewing sarcoma by correlating your histologic findings with the findings on Icc, with the findings of Icc markers. Now you are ready to request the targeted test for EWS-FLI1 gene fusion. I must note here, and I will go into the details of this later, that this test may show negative findings even if your histologic working diagnosis is strengthened by the Icc markers and you are quite confident that you are dealing with Ewing sarcoma. The reason is that there will be other types of fusions in variants, genetic variants of Ewing sarcoma, the details of which we will go into in the latter part of the discussion. And for demonstration of these variant genetic markers, you will need next generation sequencing. But for most cases of Ewing sarcoma, these techniques which are listed here on this slide should suffice. Now let's go on from Ewing sarcoma to non-Ewing sarcoma amongst the EFTs. And the first one is the BCOR. And there are two subsets in this broad group of non-ES EFTs. The first one is BCOR rearranged sarcomas. And the second group consists of these 4 tumors which are listed here on this slide. We'll start with the Icc profile of BCOR rearranged sarcoma. So histologically, I told you that these tumors show the classic pattern with variation in some subsets, and it consists of 4 elements that are listed here on this slide. And these are the 4 elements shown here on this slide: round cells, septal cells, septal spindle cells, the capillaries, which are the chicken wire capillary network, which is hiding in the septa, and the myxoid stroma, the four elements. These four elements may be present to a variable degree in the variants, different subsets of BCOR rearranged sarcoma. Here are two examples which I will just point out. There are round cells here, there are spindle cells here, and these two show mainly myxoid matrix in which there are scattered round tumor cells, and there is this well noted or well shown chicken capillary network in this variant. The spindle cell variant is not very clear in this particular photomicrograph, but in this photomicrograph you can see another variant pattern in which there is selective proliferation of the septal cells, and you also see the round cells and you see the myxoid stroma. But in this photomicrograph, the chicken wire capillary network is seen only in this part of the photomicrograph. So you have to, I will not go into all these details of the other photomicrographs that are here on the screen. In the interest of time, I want to emphasize that you have to examine these tumors very carefully and look for these four elements to come to a histologic working diagnosis. Once you have the histologic working diagnosis of BCOR rearranged sarcoma, you are ready to study the Icc profile. And I've given here what is described in the literature in terms of positive results and negative results. In positive results, you have CD99, BCOR, CCNB3, TLE, TLE1, SADB2, and NKX2.2. In terms of negative results, you have Wt1, Desmin, cytokeratin, and S100. Now, I have said here that CCNB3 is apparently negative in BCOR internal tandem duplication type of subset. This data has been given in the literature, and I have added to that, to the negative results, the recently described Icc marker for fusion protein in synovial sarcoma. This is negative in BCOR rearranged sarcomas. This will be positive in synovial sarcoma. Some other positive markers have also been described in the literature, which I have given here. So there is a long list of positive and negative markers, as you can see from this slide. And I will illustrate these to you. Firstly, the BCOR and SADB staining. In these photomicrographs, you can see that the staining is positive in different variants or different subsets of BCOR rearranged sarcomas. For example, here is BCOR ITD of the soft tissues. Here there is BCOR with partner other than CCNB3. Here is BCOR with the more common fusion partner, that is CCNB3, and here is clear cell sarcoma of the kidney, which shows BCOR internal tandem duplication. You can see that there is positive staining for both BCOR and SADB2. This is a slide which shows you the positive staining for CCNB3, the other Icc marker for BCOR rearranged sarcomas. You can see various photomicrographs in which you can see the nuclear positivity and as a positive control, it is positive also in the testes, and occasional examples of Ewing sarcoma can also show positive staining. Here is Chick rearranged sarcoma, which is negative. So this is a good marker to distinguish between different EFTs, although there can be a slight overlap with Ewing sarcoma. So this overlap is almost a constant feature in individual markers. And this overlap is further extended into the poorly differentiated synovial sarcoma. So the overlap in the Icc markers listed here on this slide, CD99, SADB2, cyclin D1, TLE1, and so on and so forth, is seen both in BCOR rearranged sarcoma and poorly differentiated synovial sarcoma. And therefore, distinguishing between these two tumors on the basis of Icc profile may be difficult, although now we have the Icc marker for the fusion protein in synovial sarcoma, but that has been a recent addition. So in the older literature, the overlap of Icc profile is still emphasized, and this is a slide which shows you the B-core staining in synovial sarcomas of all different types. You can see it is positive staining, the nuclear staining, all different subtypes of synovial sarcoma. This is TLE1 positivity in synovial sarcoma, the poorly differentiated variant. So there is an overlap in Icc, although this overlap is not that much of a problem now, because now we have this antibody which is against the fusion protein in synovial sarcoma, and that is the SS18 SSX antibody. But in the older literature, or in the even the recent literature, this overlap is emphasized. This overlap does occur, as I have demonstrated to you, but when you look at the histology of B-core rearranged sarcomas and poorly differentiated synovial sarcomas, there is no overlap in histology. So from the histologic point of view, I do not think that differential diagnosis between these tumors is much of a problem. The overlap thus has been unduly emphasized in the literature, according to my way of thinking. So this is the synovial sarcoma, the routine histology. As you can see here, this is very different from what you see in the B-core rearranged sarcoma. There are no 4 elements that you can that should be present in that are present in B-core rearranged sarcoma. You just have a round cells, and instead of the chicken wire capillary network, you have the staghorn large blood vessels. So histologically, it is not a problem. So I have given you a long list of positive Icc markers and negative Icc markers, but if you want to conserve your resources and reduce the costs, I would suggest that you can use 6 of these 13 reported markers in your laboratory. And these include positive markers such as CD99, B-core, CCNB3, and TLE1. And as negative markers, you may want to include Wt1 and SS18 SSX fusion protein antibody. So you can bring down the number of markers from 13 to 6 as a practical consideration in resource-restrained laboratories. So after using even this condensed Icc profile, you will be able to get strong confirmation or strong support, I would say, for your working histologic diagnosis, and then you are ready to move on to seek the targeted genetic tests for B-core rearranged sarcomas. There are different genetic markers in these B-core. There are variations in the genetic markers in these B-core rearranged sarcomas, B-core being the central one, but the fusion genes may be different, and all those details we'll discuss when we talk about genetic markers in the latter half of this presentation. So from B-core, let's now move on to the other group subset of non-ES. The first one is the EWS NFAT-C2 fusion sarcomas. Let's start with that first. So in EWS NFAT-C2 sarcomas, the positive staining is, I'm not going to come to the positive staining right now, but before that, I will just say a few words about the histopathology, because we are starting with histology and dividing these two tumors into broad groups. So in this particular type of tumor, you are likely to see myoepithelioma-like pattern, and you are likely to see cartilaginous foci and you are likely to see focal staghorn blood vessels. So on the basis of this, you have a working histologic diagnosis of this tumor. So this is the myoepithelioma-like pattern. And in one of the recent publications, it has been shown that this tumor, EWS NFAT-C2 fusion sarcoma, can also show cartilaginous foci, as is shown in this particular photomicrograph. So this is the Icc profile of EWS NFAT-C2 sarcoma as described in the literature. Firstly, the positive results, and the positive results include, the markers include CD99, EMA keratin, NKX2.2, PAX7, and SADB2. There is a recent notable addition to these markers, and that is agrican. And this particular marker has 93%, it is 100%, it is 93% specificity and 100% sensitivity. So this is a good marker to study for these tumors. Firstly, I just want to show you the epithelial markers in the tumor showing myoepithelioma-like pattern, and here is the EMA staining shown here in this particular marker, and this is the CD99 staining. So and this is the agrican staining, the diffuse cytoplasmic positivity in EWS NFAT-C2 sarcomas that has been recently described from an article from France. So these are the markers in the Icc profile. So you have epithelial markers and you have agrican. So if you have these markers, you have strengthened the histologic working diagnosis of EWS NFAT-C2, and you are ready to request the test for the genetic marker. So from the EWS NFAT-C2 fusion sarcoma, let's move on to EWS PAD-Z1 fusion sarcoma. And in this, you are able to see the positive markers which are listed on this slide. CD99, the myogenic markers are positive, the neural markers are positive, and PAX1 also can be positive. Because of the presence of myogenic and neural markers, this Icc profile is described as polyphenotypic. There is another tumor in EFTs which also shows polyphenotypic profile, and we'll discuss how to differentiate between these two tumors showing polyphenotypic profile. So this polyphenotypic profile will strengthen your histologic diagnosis of EWS PAD-Z1 sarcoma made on the basis of low mitotic rate, presence of hyalinized capillaries, and hyalinized stroma. So this is a photomicrograph to show you the hyalinized stroma and the hyalinized capillaries, which are helpful in coming to a working diagnosis, a histologic diagnosis of EWS PAD-Z1 fusion sarcoma. Now, in this set of photomicrographs, I'm trying to show you the polyphenotypic Icc profile. Firstly, you have CD99 positivity, which is constantly overlapping Icc marker in these tumors. Then in this photomicrograph, you have desmin. In this photomicrograph, you have nuclear staining for myogenin. In this one, for myod1. And in these two, you have the neural markers positive, namely S100 and SOX10. So this shows the polyphenotypic Icc profile of this tumor. Now, let's move on to desmoplastic small round cell sarcoma, which also shows polyphenotypic Icc profile. And then when we talk about this polyphenotypic profile, we'll come to the differential diagnosis between these two tumors showing polyphenotypic Icc profile. So in desmoplastic small round cell sarcoma, you are likely to see CD99 positivity Wt1 positivity, but I must emphasize that the Wt1 positivity is seen only with C-terminus antibody. N-terminus antibody, N-terminus of Wt1 is lost in the EWS-Wt fusion in desmoplastic small round cell sarcoma. Therefore, the antibody which is for N-terminus antibody is negative in desmoplastic small round cell sarcoma. So you have to use C-terminus antibody. This is not readily available, so you have to make a special effort to have this available, or you may have to send it to a reference laboratory. Then the other markers which are positive are listed here on this slide: Desmin, NSC, NKX 2.2. So again, myogenic markers, the neural markers, and in addition, there is an epithelial marker in desmoplastic small round cell sarcoma, desmoplastic small round cell tumor. So you have this polyphenotypic Icc profile in this tumor. And I have emphasized that Wt1 only for C-terminus antibody. So when you have a working histologic diagnosis of desmoplastic small round cell tumor based on your knowledge of the site of the tumor, the primary site of the tumor, the presence of desmoplasia, you are this type of polyphenotypic Icc profile will strengthen your histologic working diagnosis of desmoplastic small round cell tumor. This is the characteristic histology of desmoplastic small round cell tumor, and this is the nuclear staining with C-terminus Wt1 antibody. This is a cytologic preparation. This is histologic preparation, and this is a cytologic preparation to show you the positive staining. Now, how to differentiate between these two extended Ewing family tumors which show polyphenotypic Icc profile: the EWS PAD-C1 fusion sarcoma and the desmoplastic small round cell tumor. CD99 can be positive in both. Desmin and NAC can be positive in both, but keratin is positive only in desmoplastic small round cell tumor, whereas it is negative in most of the examples of EWS PAD-C1 cases. Wt1 C-terminus nuclear antibody is positive in desmoplastic small round cell tumors, whereas Wt1 antibody of both types, that is C-terminus and N-terminus, is negative in EWS PAD-C1 fusion sarcoma. So this type of study of differences in the Icc markers will enable you to differentiate between EWS PAD-C1 fusion sarcoma and desmoplastic small round cell sarcoma. Although I must point out that you are relying primarily on one antibody, and that is the keratin for desmoplastic small round cell sarcoma, because the C-terminus antibody of Wt1 may not be readily available. And it can be a difficult situation to differentiate between these two on the basis of Icc profile alone, although you can always get support from other features. And and these two tumors make this point again very emphatically, that is, you have to take into consideration all features, clinical features in terms of primary site, the histologic features into consideration when you try to differentiate between these two tumors. So the site, namely abdominal in desmoplastic small round cell tumor, soft tissue in EWS PAD-Z1 tumors, and histology, that is fibrous septa around nests of primarily round cells in desmoplastic small round cell tumors, and this absence of these, the absence of these septa is to be noted in renal desmoplastic small round cell tumors. This is an exception. I'm just pointing out the difficulties in coming to this diagnosis in these two tumors. And it has been also pointed out by this author that the myxoid fibrous stroma in EWS PAD-Z1 can mimic the desmoplasia in uh, uh, desmoplastic small round cell tumors. This is a rare type of situation, but just for the completeness of uh, pointing out the difficulties in the differentiation between these tumors, I am pointing out these details. But on the basis of clinical features, histology, and the differences in the Icc profiles, in most of the cases, you should be able to differentiate between these two tumors which show polyphenotypic Icc profiles. But in practice, there are always difficulties in textbooks and in articles and in presentations like this. It may sound relatively readily possible, but in practice, it may not be. So I'm just giving that word of caution to you in my presentation. So as I already mentioned to you, clear differential diagnosis can be difficult, but combination of various features will enable you to make the differentiation in between most cases. When you have done that differentiation, you are ready to request the for genetic marker of the more likely diagnosis, that is the EWS PAT-Z1 fusion sarcoma or desmoplastic small round cell sarcoma. Now we move on to the last tumor in this series, and that is the Icc rearranged sarcoma. And there are these markers described here in this in the literature. CD99. As you will see, CD99 figures virtually in every EEFT. So CD99, Wt1 N terminus, this is important. And then ETV is positive. This is a very important marker. It has a specificity and sensitivity of 95 and 90%. And Wt1 has a positivity of 95 and 19. And 95, it is positive in 95% of the tumors studied in one series here mentioned in this article. And so it has a specificity of 95% and a sensitivity of 81%. So these are pretty good positive markers, mainly Wt1 and ETV4. Another marker, two other markers have been mentioned in the literature, that is the epithelial marker and the muscle marker. So the most important markers for this tumor, Icc rearranged sarcoma, are ETV4 and Wt1. It has been pointed out by this author that both these markers are positive in 85% of the cases of this tumor. In the literature, there is also a description of another positive, nearly specific, 100% specific marker, and that is DUX4. But this has been tested in only 5 cases of Icc rearranged sarcoma. So we'll have to wait for further confirmation of this particular marker in a larger series of these tumors. So for the time being, ETV4 and Wt1 are the most important Icc markers for Icc rearranged sarcoma. This slide shows you the positive staining for CD99 as is seen here. It is membranous. Note that it is diffuse strong membranous in this particular case. And this is Wt1 staining, the N-terminus antibody. This is also the, excuse me. So both these are showing the Wt1 positive staining. And this is the another series showing the CC of Icc rearranged sarcomas showing the positive staining for ETV4. The previous one was Wt1. As you can see here on the left-hand side are the H&E pictures of Icc rearranged sarcoma, and on the right-hand side, you have the positive staining for ETV4, which is diffuse nuclear staining. So Wt1 and ETV4. This is another photomicrograph to show you that CD99 staining can be also focal. In the previous photograph, I showed you diffuse strong membranous staining. Here it is focal cytoplasmic staining. So both types of CD99 staining are seen in Icc rearranged sarcoma, but the most important Icc markers are the Wt1 as shown here and the ETV4 which I have shown you in the previous slide. Negative markers have also been described in the literature, and these are listed here on this slide: TLE1, myogenin, S100, and so on and so forth. And BCOR is negative, CCNB is negative. So we have a long list of positive and negative markers, but we mainly rely on Wt1 and ETV4 as the Icc profile of Chick rearranged sarcoma in terms of getting a stronger support for histologic working diagnosis. I've already said DUX4 needs to be confirmed on a larger series, so we leave it at this point, and we'll just should confine our attention to Wt1 and ETV4. Although I must also mention that you may want to do the negative markers, the TLE1, BCOR, and CCNB3 to rule out BCOR rearranged sarcoma. So once you have this profile based on this condensed list of Icc markers, namely Wt1, ETV4, and these negative markers, you are ready to this type of condensed profile will provide a strong support for your histologic working diagnosis of Chick rearranged sarcoma, which you have made on the basis of these histologic features mentioned here on this slide. And just again, focal rhabdoid change is one of the histologic features which has been mentioned in the literature, and this slide will show you the excuse me, the rhabdoid change, and here you will see the CD99 staining, and here you will see the Wt1 staining. So this is the Icc profile of all these markers. I think ETV4 is of particular importance. This particular marker is positive irrespective of fusion partners. And I haven't described the different fusion partners of Chick rearranged sarcomas. I will come to that point when we talk about genetic markers. But at this point, I must emphasize that ETV4 is positive irrespective of fusion partner. ETV4 is also important because as far as demonstration of genetic marker by these tests is concerned, there can be underperformance of these tests, and you might get a false negative result in as many as 20 to 40% of cases of Chick rearranged sarcoma. So in these types of cases, demonstration of ETV4 is almost like demonstrating a surrogate marker for the gene, for the genetic marker of Chick rearranged sarcoma. So ETV4 is very important from that point of view. So I have discussed with you the Icc profile of all these 5 entities in the extended Ewing family tumors. And as we will see, I have given you, we have talked about a long list of various Icc markers, which are more than 25 in number. What I want to suggest what I am suggesting in this slide, that you can use a condensed Icc panel from practical point of view to conserve the resources. And I have listed about 15 to 18 Icc markers on this slide. Going through this is not going to achieve anything, because you may not be able to remember all these, and you need to have a printout in front of you as to what type of antibodies, what type of condensed panel we can use. So to go back to the individual tumors and to point out the most important supporting Icc markers for working histologic diagnosis, you start with Ewing sarcoma. CD99, NKX2.2 are the 2 most important markers. BCOR, CCNB3, and TLE1 are the most important positive markers for weak or rearranged sarcoma. Agricon, EMA, and keratin are most important for EWS NFAT-C2 fusion sarcoma. Myogenin, desmin, NSC, and synaptophysin are the most important markers for EWS PAT-Z1 fusion sarcoma. Wt1 C-terminus antibody and keratin are the most important ones for desmoplastic small round cell sarcoma, and ETV4 and Wt1 N-terminus antibody are the most important ones for sick rearranged sarcoma. So you may want to request negative stains also to strengthen your histologic working diagnosis, and the negative stains that you may want to use for different entities are listed on this slide. For Ewing sarcoma, Wt1 and BCOR. For BCOR rearranged sarcoma, Wt1 and SS18 SSX. Fusion protein antibody. EWS NFAT-C2, the negative marker will be Wt1. For EWS PAT-Z1, the negative marker will be EMA. For desmoplastic small round cell tumor, the negative marker will be Wt1 N-terminus. And for chick sarcoma, the negative markers will be TLE1 and BCOR. So you may want to use both positive and negative markers in the workup, ICC workup of these cases. And from practical point of view, I have suggested to you a condensed ICC panel in order to conserve your resources. Now, there will be cases in your experience in which you may not be able to come to a working histologic diagnosis. So what do you do in this case? I would suggest that you request the most helpful positive stains for each entity, as I have indicated previously. If ICC also, after taking this step, even then you are not able to get a working diagnosis, then you will have to go to general or general next generation sequencing, so that you will be able to recognize a positive known entity, or you may recognize a new marker. And even at this exercise, you may not be able to demonstrate any marker, then you just call it undifferentiated, unclassified sarcoma. So this is, I am pointing out all these just to complete the picture of the practical experience of these complex list of tumors. So you have to live with this reality. And this is the slide again that I'm showing you, that if you don't have a working histologic diagnosis, you may want to try these tumors, these positive markers step by step, and hope that one particular set of positive markers will be able to provide you with a working diagnosis. So now we move on to the genetic markers. So you have a working diagnosis on the basis of clues from the review of clinical and histologic data, and also Icc profile. So the next step is to demonstrate the molecular genetic marker. And these are now in the next few slides, I'm going to give you the details of the genetic markers. We need not go through every genetic marker as I show you the slides, because again, as I pointed out to you, that there are a number of them and it is difficult to remember them. So later, when you have the slides available to you, or in the literature or in the textbooks, you can look these up. So in Ewing sarcoma, this is the prototype, and the fusion is between the members of FED gene family and ETS gene family. And there are various fusion involved in this, and we'll come to that as we go on. Then the second is the round cell sarcoma, showing the fusion between FET gene family and non-ETS family. And there are two subsets in this, EWS NFAT-C2 and EWS PAT-Z1. Then the third one is the desmoplastic round cell sarcoma, in which you have fusion between EWS and WT1 genes. And you have B-core rearranged sarcomas in which you have 4 subsets, and you have the fifth one, that is chick rearranged sarcoma, in which you have various partners with for the Icc gene, which are pointed out on this slide here. So the B-core rearranged sarcomas and Icc rearranged sarcomas are sarcomas which show a presence of undifferentiated round cells and show non-FET, non-ETS fusion. So these do not belong to actually the Ewing sarcoma group of tumors, but since these have characteristic features of lack of differentiation, and there is fusion of between 2 genes, I have included them in the extended Ewing's family tumors on the basis of presence of round cells, which are undifferentiated on morphology, and on the basis of genetic markers, which show fusion between 2 genes. So I mentioned to you that B-core rearranged sarcoma has 4 subsets. Again, we need not go into the details of these. The first subset is the B-core fusion sarcoma in which you have these various partners. The commonest one is CCNB3 in 90% of the tumors. Then you have soft tissue B-core rearranged sarcomas in which you have internal tandem duplication of exon 16 of B-core gene. And there are certain variants in this tumor which are mentioned here on this slide, the histologic and clinical variants. Then you have the third variant, clear cell sarcoma of the kidney, which shows internal tandem duplication of exon 16 of B-core gene, and this is seen in 90% of clear cell sarcomas, although in a small minority, other types of genetic markers will be seen in this tumor, as is shown in this particular slide. The fourth set is mentioned here on this slide for the sake of completeness, that is endometrial stromal sarcomas and CNS neuroepithelial tumor also show B-core gene rearrangement, but these tumors are beyond the scope of this presentation. So we are going to stick to the first 3 subsets. So I have mentioned to you the 5 tumors in extended Ewing family tumors. There is a 6th one, which is undifferentiated, unclassified sarcomas with no distinctive genetic markers or Icc profiles, and these occur mostly in soft tissues and occur at all ages. And there are histologic subsets described in the WHO classification of these tumors, and there are isolated reports of loss of these types of genes in isolated examples of undifferentiated sarcomas. I think these need to be confirmed, and as time passes, perhaps we will get some identification of genetic markers in a subset of these tumors. So we are going to leave these tumors at this point, and we now go on to the details of gene fusions in Ewing sarcoma. As I mentioned to you, there is fusion between gene of FET/TET family and a gene from ETS family. And there are various genes mentioned here on this slide. And as you can see here, in 85% of cases of Ewing sarcoma, there is fusion between EWS and FLY1, and there is fusion between other 2 genes in a small percentage of Ewing sarcoma. The gold standard is molecular genetic marker demonstrating fusion between EWS and FLY1 gene, or other fusions shown here in this slide. And this demonstration will have to depend on NGS rather than FISH or RT-PCR. I must point out that all these genetic variants are described in the literature, but they are not associated with any histologic subtype or any particular type of difference in behavior. So these are genetic variants. Clinically and histopathologically, they do not show any differences. This slide again is going to the details of the partners, the fusion partners in different variants of Ewing sarcoma. We need not go into the details. I'm showing you this slide only to indicate that if your initial study for EWS FLY1 fusion is negative, you don't say that this is not Ewing sarcoma. You go on to look for other fusion partners by other types of tests, genetic tests like RT-PCR or NGS. So I'm showing you this slide just for the sake of making that particular point. In round cell sarcomas, which show EWS NFAT C2 fusion, now these slides are also meant to show you the translocations in the chromosomes, which can be demonstrated by cytogenetics. We don't need to do cytogenetics anymore. We demonstrate the fusion between two genes by various molecular genetic tests. I'm showing you these slides of chromosomal abnormalities in these tumors, just to point out that in some tumors there are translocations, in other tumors there are inversion of a particular chromosome, which brings two genes to close proximity, and therefore there is fusion between these two genes, and this leads to reduced sensitivity of the FISH test because of the close proximity of these two genes. There is translocation in desmoplastic small round cell tumors, and there is also this fusion between again, the point that I want to make is there is fusion between the C-terminus part of Wt1 gene and EWS gene. So the last one is the chick rearranged sarcoma, in which this is the translocation, and the commonest partner is DUX4. In a previous slide, I had shown you other partners. There are a number of partners which have been described in the literature. In BCOR CCNB, there is a inversion, not a translocation, of short arm of X, resulting in fusion of nearby genes. And in a subset of BCOR rearranged sarcoma, there is internal tandem duplication of exon 16, and there is no translocation or inversion in these tumors. This is just to go into the details to understand what is going on in these tumors at the genetic level. Now, what are the methods that we use for demonstration of these gene fusions? FISH, RT-PCR, DNA, RNA-based next generation sequencing. You need appropriate quantity and quality of the material for doing these tests. Fresh snap frozen tumor is the best choice, although you can use sections from formalin fixed paraffin embedded tissue. You have to be sure that neutral, buffered, non-recycled formalin has been used and you have avoided long fixation. So this type of material is acceptable for large retrospective studies. Now, the type of sample that you need for NGS, I have already described that for you in my part one of this presentation, but I just want to make one point, and that is, if you are looking for whole genome sequencing, you need a high molecular weight DNA, and for that, you need fresh tissue. If you are looking for a targeted sequencing, a low molecular weight DNA in formalin fixed paraffin embedded tissue should suffice. So this is just to make that particular point. Now, FISH technique suits admirably for most of resource restrained laboratories or even major laboratories. And the advantages of FISH technique are that you require a small sample, although you can use also sections. This technique is sensitive and specific. There is a short turnaround time. It is a molecular morphologic test because we actually visualize the marker under the microscope in the cell, and it is suitable for resource deficient laboratories. There is one limitation though, and that is targeted approach is possible with only in limited number of commercially available probes. So you may have to use RT-PCR or NGS when these probes for particular types of tumors are not commercially available. So this is the slide just to point out the FISH technique in EWS Fly1 fusion. This shows the fusion of green and red signals in the nuclei demonstrating EWS FLY1 gene. Now, in certain tests, you can get false negative results. And I have given here an instance of reduced sensitivity of FISH method in EWS PADS Z1 fusion round cell sarcoma. And this is due to the proximity of the gene partners on chromosome 22, which interferes with the sensitivity of FISH technique. I have also already pointed out the underperformance of these tests in Icc rearranged sarcomas and the importance of ETV4 as an Icc marker in this type of situation to come to a diagnosis, a definitive diagnosis. Also, in Ewing sarcoma, in certain situations, the EWS FLY1 gene marker may be negative, so you have to go in for demonstration of other markers, which I have shown you in other types of other genetic variants of Ewing sarcoma. So if you have, if FISH is unavailable because of lack of the commercially available probes, you will have to go to RT-PCR as the next choice. And in RT-PCR, you can use the RNA extracted from paraffin blocks, and it has been demonstrated in the literature that you can get a good yield from this paraffin, this formalin-fixed paraffin embedded material. So I will just briefly now summarize what type of tests, genetic tests are required, molecular genetic tests are required for definitive diagnosis of each of these tumors in the Ewing sarcoma, extended Ewing family tumors. Ewing sarcoma, FISH, or RT-PCR. If these two tests are negative due to uncommon fusion partners, you need to do RNA-based next generation sequencing. In BCOR rearranged sarcomas, FISH or RT-PCR, or RNA-based next generation sequencing for uncommon fusion partners, or DNA-based next generation sequencing for demonstration of internal tandem duplication of exon 16 in this subset of BCOR rearranged sarcomas. In EWS NFAT-C2 fusion sarcomas, you need to do RNA-based next generation sequencing. In EWS PAD-Z1 fusion sarcomas, there is reduced sensitivity of FISH, as I have already pointed out, because of the close proximity of fusion partners, and therefore you will have to do the next generation sequencing, or in this particular case. When you have the negative result for this slide just discusses the particular instance of Ewing sarcoma. This is the commonest tumor in this family, and therefore I'm making an extra slide for this. That is, you get a negative result for common genetic marker in Ewing sarcoma, and you don't stop there. You do think of rare genetic markers for Ewing sarcoma, or you think of an alternative diagnosis on histologic assessment to be confirmed by a genetic marker for non-ES. Your histologic assessment may be not appropriate, and you may also actually be dealing with a non-ES rather than an ES in this type of situation. Although you should have confidence in your histologic assessment, and you should go for the alternative method to demonstrate the rare genetic markers in Ewing sarcoma. A needle biopsy may interfere with the adequacy of sample because if there is necrosis, sclerosis, or inappropriate fixation, or delayed delivery. I'm just pointing out these factors to you because appropriateness of the sample that you submit for genetic markers is very, very important. And your negative result may be related to inappropriateness of the sample that is submitted. So these are the rare variants of Ewing sarcoma in which you have to demonstrate by the next generation sequencing rather than by the usual FISH or RT-PCR. For desmoplastic small round cell tumors, you need to do FISH. If this doesn't work or this is not available, you can do RT-PCR. For chick rearranged sarcomas, the positive result can be obtained by FISH, RT-PCR, or DNA-RNA based next generation sequencing. This is diagnostic, but false negative result by FISH, RT-PCR, or DNA-RNA based next generation sequencing can be seen in 20 to 40% of the cases, as I've already pointed out. And in this situation, the Icc markers are particularly helpful, particularly ETV4. The advantages of next generation sequencing are pointed out on this slide. You need only a small amount of material. This is the most definitive test with the availability of appropriate material. Again, I cannot overemphasize the importance of appropriateness of the material. The disadvantages obviously are very high cost and long turnaround time. And for that reason, this particular test may be out of reach for many laboratories in the developing countries. So you have to have a reference lab to which you can send your sample for the definitive diagnosis of these tumors. Then I'll just briefly go over the biologic relevance of genes involved in these fusions. This is a very important point in order to understand what is the exact biologic and clinical relevance of these tumors. We look upon them just as diagnostic markers, but they are far more important. Their significance goes beyond their being diagnostic markers. For example, all these genes that I mentioned here in these fusion partners and also in IgG, Icc overexpression, all these genes are involved in one or more of the following processes, that is embryonic development, cell proliferation, differentiation, and transcriptional repression. So the molecular genetic marker is not just a gold standard for diagnosis, but it is also of pathobiologic and clinical relevance. The genetic marker for Ewing sarcoma is being explored and studied for its possible significance in tumorigenesis of Ewing sarcoma and designing targeted therapy for Ewing sarcoma. So I'll just briefly go over these points to you. EWS51 gene is an aberrant transcription factor for inducing expression of genes with oncogenic properties. EWS and ETS factors are implicated in DNA repair, cell differentiation, and cell cycle control. And it has been demonstrated that ES-like tumors do form after injecting EWS1 expressing cells into SCID mice. So there is ample evidence to suggest that there is the EWS1 gene fusion plays a role in the oncogenesis of Ewing sarcoma. And therefore, EWS1 gene is considered to play a primary role in ES tumorigenesis. As far as other gene fusions are concerned, the role of these genes, for example, DUX4 in chick rearranged sarcomas or BCOR in BCOR rearranged sarcomas are been poorly defined and need to be studied further. So what is then this is the biologic relevance of these fusion partners. What is the clinical relevance? The clinical relevance is in terms of designing targeted therapy. However, there is a problem because of the disordered structure and lack of enzymatic activity of fusion transcript. Because of this fusion transcript does not lend itself to the targeted therapy. And therefore, targeted therapy is directed now to epigenetic mechanism, which I pointed out in one of the slides. I didn't read it out because to save time, but there are epigenetic mechanisms also involved in the tumorigenesis related to EWS1 gene. And therefore, these are being now explored for developing targeted therapy. So novel approach to therapy is being approached. Now let's move on to just briefly, the clinical importance of accurate specific diagnosis. The accurate specific diagnosis of any tumor means the medical oncologist is able to give specific treatment for that particular patient. In established small round cell tumors, you have specific therapies for specific diagnosis, as is shown on this slide. For Ewing sarcoma also, there is a specific therapy, but unfortunately, for non-Ewing sarcomas in the extended Ewing family tumors, we still do not have a specific therapy, and the medical oncologist still uses the same therapy for non-ES as he uses for ES. So same therapy is used for all these tumors. Then you might ask, what is the point of extending yourself so much to make a specific diagnosis? The importance in terms of determining or predicting the prognosis. For example, the response to the therapy, which is the ES, the therapy in ES is 76%. It is only 30% in desmoplastic small round cell tumor. It is 70 to 90%, even better than ES in B-core rearranged sarcomas. In chick rearranged sarcomas, it is not so good, and it is in EWS NFAT C2 fusion sarcoma, it is very good, 90%, whereas in EWTS PAD-C1, there is no data available yet. So the question is that you have to, the point is that you have to make a specific diagnosis so that the medical oncologist can predict the prognosis in that particular case, although he uses the same therapy for all these tumors. So just to briefly summarize, last couple of slides, we started with the assumption for this presentation that all non-EFT assumption that the established Srcds have been ruled out. We emphasize the proper triage of the needle core biopsy, which is very important in getting the proper results for all these markers. Then collection of data in every case for clues on the clinical data, the histologic data. The ultrastructural markers are not out of fashion now to come to a working diagnosis, and then you request the Icc markers to strengthen your working histologic diagnosis. And when you correlate your findings of Icc markers, histology, and clinical data, you have a firm working diagnosis, and you are ready to request targeted tests for genetic markers to confirm the firm working diagnosis. For all these tumors, you need to have a pre-established access to reference laboratory in order to come to a definitive diagnosis. So the last 3 slides give you the references, which are very important in this. I need not go into this. We can't go into this. There are several references which you can have access to when you get access to the slides of my PowerPoint presentation. Thank you for your attention. I have extended the time, firstly because of the technical problems, and then later because of the material that I tried to cover. I thank you for your attention, and Dr. Rifat, you can take over. Thank you.
Thank you so much, Dr. Joshi, for this excellent talk on Ewing's family of tumor, which was emphasizing on the ancillary tests and so many different molecular methods and tests that can help in the diagnosis. I'm looking online for questions, so let me see. So one question that I can see is that in a developing country with not much of availability to do molecular tests, so what is your most practical approach for them? What is your suggestion?
As I emphasized in my presentations, a very careful study of clinical features, the imaging studies, the histologic features, the uh, to come to a working diagnosis is very important. If you stringently follow these directions, I believe that you can come to a working histologic diagnosis in vast majority of these tumors. Once you have a working histologic diagnosis, you want to use the ICC profile, and I have given you the condensed ICC panel, which is suitable for resource restrained laboratories. So, and I have also given you the list of the best positive markers for each of these tumors. So, if you want to really limit to a small number, you can use that list. It is available in the PowerPoint presentation. All these slides are available in the PowerPoint presentation. And when the PowerPoint presentation becomes available to you, you can get printout from these slides and use these in your practice. Uh, uh, Again, I must emphasize that to come to a definitive diagnosis, you can use FISH technique very well. You can establish FISH technique in your laboratory. It doesn't require vast resources, but if it is not possible for you, you need to have a reference lab, pre-established access to a reference lab where you can send your case. The clinicians these days will almost insist on a specific diagnosis in these tumors, not give a specific therapy, but at least to come to some understanding of predicting prognosis. So this is what you can do in your situation. Thank you.
Thank you, Dr. Joshi. So there is another question. So this is about, is there any relation to clear cell sarcoma and B-core related Ewing sarcoma if it is in the kidney?
Well, Ewing sarcoma in the kidney is completely different from the clear cell sarcoma of the kidney. There is no relationship between those two. They are different. The only thing I can point out is Ewing sarcoma of the kidney occurs more often in adults rather than in children, although it can be seen in children too. And clear cell sarcoma of the kidney is virtually confined to the pediatric age group. But histologically, ICC wise, and from the point of view of molecular genetics, they are completely different tumors.
Thank you, Dr. Joshi. Here is one more question. Is B-core positive in both B-core CCNB3 and B-core ITD?
Well, B-core is positive in both, yes. But B-core, the CCNB3 will be negative most likely in B-core ITD, because there is no fusion partner there in these tumors. In B-core CCNB3 fusion sarcomas, you will get CCNB3. In both these tumors, B-core fusion sarcomas and B-core ITD, you will get positive staining for B-core.
Okay. Thank you, Dr. Joshi. Let me see if there are some more questions for you. What is your practical approach to differentiate classical Ewing sarcoma from um, clear cell sarcoma using immunohistochemistry?
Clear cell sarcoma of the soft tissues?
No, kidney.
Of the kidney.
Yeah.
Well, firstly, the major difference, histologic difference. Ewing sarcoma of the kidney will consist of uniform, small round cells which are evenly spaced, will show very little stroma and very few blood vessels and a low mitotic activity. So the histologic picture is completely different from clear cell sarcoma of the kidney, which the latter, that is clear cell sarcoma of the kidney, consists of, as I have already emphasized, four basic elements. that is the round cells, which are called the cord cells, which may be arranged in cords or nests, the spindle cells or the septal cells, which form septa, the myxoid stroma, and the chicken wire capillary network. So these are the four basic histologic elements of clear cell sarcoma of the kidney, which show a classic pattern in vast majority of clear cell sarcoma of the kidney. So you will be able to recognize these four elements and the classic pattern in vast majority of clear cell sarcoma of the kidney, and even in the beak or rearranged sarcomas of the soft tissues. But in a minority of the cases, there will be variant patterns. And I have already demonstrated the variant patterns in part 1 of my presentation. And these variant patterns result from selective proliferation of one or more elements, or selective presence, abundance of one or more elements, one or more of the four elements. So there may be selective proliferation of round cells, giving you a pattern of cellular clear cell sarcoma of the kidney, which may resemble Ewing sarcoma. But in this, you have to look for the septal cells, the chicken wire capillary network, and the myxoid stroma, at least in some foci. It may not be present in every section of that clear cell sarcoma of the kidney, which might resemble Ewing sarcoma in some fields, but when you have in clear cell sarcoma of the kidney, you are not dealing with a biopsy. Biopsies are not done in clear cell sarcoma of the kidney. You are dealing with a resection, and you have abundant material to look at. So when you look at all the sections, at least in some of the sections, you will be able to recognize the four elements and the classic pattern that I have described for you. If that is not present in your sections, then you have to rely on the ICC panel and the molecular genetic marker. But I think that situation will rarely arise. In most instances, you will be able to distinguish between Ewing sarcoma and what is called as the cellular variant of clear cell sarcoma of the kidney. And you have to use ICC panel, of course, to distinguish between the two. Thank you.
Thank you, Dr. Joshi. There is another comment. It's more of a comment, I guess. Just a remark that nowadays pathologist is overburdening one with genetic profile of tumors, encompassing the job of molecular geneticist, and it makes us far away from morphology, which is the basis. It is too much to serve oncologists to give predictions that are in the scope of astrology. So maybe you want to answer that concern?
Well, it is not really scope of astrology. There are specific figures available in the literature for a 5-year survival after the therapy is given in each of these different tumors. And as far as his comment regarding morphology is concerned, I fully agree with his comment that we are basically morphologists, and that's why I spent the entire part 1 of this presentation on constructing histologic profiles of these tumors. And I emphasize that when you do that, you are ready to request targeted ICC panels to conserve resources and to save costs. And you can come close to a very firm diagnosis in these tumors. But it has been emphasized repeatedly, and I think correctly, that the gold standard is demonstration of the genetic marker. And in future, for all we know, in future, specific therapies may become available. Targeted therapies may become available in each of these tumors. So coming to a specific diagnosis, even at this point, on the basis of various types of studies, is worth it. Thank you.
Thank you so much. I think this is a concern with Many of us would think that like we should not forget morphology while analyzing a case, but at the same time we cannot ignore the recent advances which are
Absolutely.
directing
Right.
therapy. No, thank you
Yeah.
so much, Dr. Joshi, and thanks to all of our viewers for their support and watching this lecture. And I think with that, we have come to the end of this Q&A session. I don't see any more questions. And if you have any questions, you can send directly to Dr. Joshi, or you can send the question to us. We can forward it to Dr. Joshi. And we want to thank again Association of Indian Pathologists of North America, that is IPNA, for organizing with PATCAS this lecture series on pediatric pathology with Dr. Joshi, and thanks to them. And we have our next lecture coming up that is on March 8th, and we will switch to an ophthalmic pathology lecture. And our speaker will be Dr. Franz Vogt, who is an ophthalmic pathology at University of Pennsylvania. So that is on March 8th again, 9 a.m. Eastern time. So hope to see you at that time. And thank you again. Thank you, Dr. Joshi, once again for your time.
Thank you, Dr. Rifat Manan, for giving me this opportunity. And thank you for your attention, all those who have listened to this presentation. Thank you.